to do is we're going to mark off those borders of the posterior or lateral triangle. First, there's our sternocleidomastoid. All right, we'll go ahead and put one color through there just so that we can see it. And then we can see our trapezius just behind there. Okay, so there's our posterior border. We can also see the big flat muscle right through there, which is the platysma. We can see it going all the way up to the mandible and then going all the way down to the clavicle as well too. So we're going to go ahead and we're going to get rid of that muscle. Okay. Now, as we do that, we can very clearly see that anterior jugular vein, right? So remember, the anterior jugular vein is going to be found right on top of where we see the sternocleidomastoid. One thing to remember about veins is that they're draining down this way, right? Like arteries are going this way, and so they're named as they move away, but the veins themselves are starting here and then coming down. So one of these veins is right behind the mandible, so it's retromandibular vein, feeds into that anterior jugular vein, then goes down to the subclavian vein, which joins the brachiocephalic, right, trunk, as we saw last, or excuse me, brachiocephalic vein, and then drops into the right atrium of the heart. So let's go ahead and at least remove these two structures right through there so that we can see our deeper structures. Now, once we do that, we can see pretty clearly our splenius capitis right there. We'll highlight it. The next muscle that we can see right there beside it is our levator scap. What nerve did we say we would find on top of the levator scap? The spinal accessory. So if we turn up the detail, hey, listen, be confident, say it out loud, say it wrong. What happens every time you say something wrong out loud? You remember it better. Okay, it triggers a response. So saying it wrong out loud is a good thing. Actually, not showing it. Okay, now the next muscle down, we can just barely see it. See, it's just right there, that little bitty guy. Now when I highlight it, we're only going to see a small portion. See how small it is? All right. Next muscle right through there is going to be our middle scalene. And then, of course, our anterior scalene. Now, one thing that's important for us to remember clinically is that passing between the anterior and the middle scalene is the brachial plexus, but also the subclavian artery. Okay, but the subclavian vein actually passes anterior. Hey, Dr. Taylor, it's good to see you. So, clinically, the anterior or the middle scalene could actually compress the nerves, and it could also compress the subclavian artery, causing coldness down the extremities or even pain or paresthesia because of the nerves, but it's not going to compress the subclavian vein. Does that make sense? Because it's in front of the scalenes. So that's clinically important for us to know. Now, if we look right through here, we can see the omohyoid, and we're going to notice something that we've seen before. The table doesn't give us the specific names that we want, right? So if I turn this down just a little bit, we can appreciate the superior belly of the omohyoid versus the inferior belly of the omohyoid. So we have to be aware that this would be superior belly of the omohyoid and that this would be the inferior belly of the omohyoid. Now, because we can see the deeper structures here, we can go ahead and point out the internal jugular vein as well, too. Okay? Of course, that's going to go up into the skull through the jugular foramen. We're going to talk about some of the drainage points through there and the sinuses that are inside of our skull, and we'll see all those as well. We can also see down through here a little bit of our artery, right? So we can see our subclavian artery passing through there, and we're going to see some of the different branches of that in just a second. Let's go ahead and let's add back in that sternocleidomastoid just so we can see where that border is. Oh, not notes. Actually, let's put those notes in there. Can you see them? Can't even see them. Oh, because it's probably because of this. So we get that. So we can see the lymph nodes that are in there too, just because you're going to use that in visceral diagnosis as part of your head and neck assessment. It's going to be palpating those lymph nodes through there. So again, now we can see that border. So we can see that the omohyoid exists in both the anterior triangle, but it also exists in that lateral triangle as well too. All right. So again, the omohyoid also gives us another branch. All of this stuff that we see up through here is going to be our occipital triangle. Okay, and then what did we say this one was going to be? Someone saw it a minute ago. The subclavian, yeah. So the omohyoid is going to be responsible for further dividing that lateral triangle as well too. and we'll see specific structures through there. So let's clear off our drawing. Now, if we look through here, we can see that there's an artery that's passing through there. Now, the artery itself is the transverse cervical artery. And if we had a cadaver, we actually would take the trapezius, flip it upside down, and we would see the spinal accessory nerve running along the posterior, or the anterior aspect of the muscle. But you'd also see the transverse cervical artery passing there as well too. But it also gives us some other branches as well too. One of the branches it's going to give us is going to be the dorsal scapular, traveling with the dorsal scapular nerve. And what did we say the dorsal scapular nerve innervates? Levator scap, rhomboid major and minor. And we said if there was paralysis of the dorsal scapular nerve, that would cause flared scapula. Good job. Nice. Okay. So these are the major components that are through there. There's our veins and stuff that we're seeing through there. So we're getting an appreciation of what it looks like here. And then this thing that you see here, this is one of the lymph nodes. They're just kind of swollen. Any questions about anything we're seeing at this point?
Here is the platysma. Okay, that's that superficial muscle. We saw it yesterday. And remember, we saw, let's see if we can get it to come through, that anterior, middle, and posterior supraclavicular nerve, anterior, middle, and posterior supraclavicular nerves that are popping out of the platysma. On this model, we can actually see that really well. And some of these nerves, when we look at them, like in this one, we won't see it quite as well. So let's go ahead and let's remove that. Remember, that's going to be associated with that superficial fascia that surrounds the entire cervical region, and it's very intimately associated with it. The next thing we can see is that big muscle that's going to divide that anterior triangle versus the posterior triangle, which is that sternocleidomastoid. And remember, that's a great landmark for a lot of different structures, okay? So it helps us be able to see the external jugular vein, which is going to be seen just going right over the top of that muscle. Remember, if we get rid of the sternocleidomastoid and we look deep to it, we can see the internal jugular vein right underneath it. And then, of course, remember at the very front, we saw that anterior jugular vein right there. Anterior jugular vein is very superficial. The external jugular vein is very superficial. The only one that's very deep is that internal jugular vein. Okay. Let's put that SCM back where it was so that we can see it just in relationship to some other structures. And we're going to begin by just looking at that posterior or that lateral triangle. And just for clarity, it's written as posterior triangle on your sheet, okay? And a lot of times that's how it's referred to, but clinically, we're in anatomy, they call it the lateral triangle. So remember that posterior border was our trapezius, right? Right. I'm not going to highlight that because that's one of our muscles from musculoskeletal anatomy. You've seen it a lot. I don't think you need me to really spend too much time talking about that. The next muscles that we're going to see coming down through there are going to be the splenius capitis. Okay, so we're just turning it just a little bit more. We can see our splenius capitis muscle. Remember, we said if it's called capitis, it goes to your head or your cap. I always say cap because where you put your hat, right? We said the exception to that was what? Which one's called a capitis that doesn't go to your skull? The oblique capitis inferior. So remember, inferior, superior does actually go to it. Okay, so the next muscle down that we can see right through there is going from the scapula up to C1, 2, 3, and 4 transverse process. So remember, that's your levator scapula. We said on top of that we would always find a nerve. Do you remember what nerve that was going to be? The accessory nerve, yeah. So let's see if we can see that, okay? Let's add the detail back in and see if we can see it. And you can see it right there. That nerve right through there is the spinal accessory nerve. Okay. Move that detail back down. Okay, so we got our splenius capitis. Let's go ahead and we'll give it color. We'll tag it so we can see it. And then we come to our next muscle, that's that levator scap. Tag that one too so we can see it. And then we come to those anterior scalene muscles, anterior, middle, and posterior scalene muscle. So we can look right through there and we can see the middle. It's pretty prominent, pretty big. You can look in front of that and see the anterior scalene muscle. Okay, both of those are pretty easy to identify. Typically with the posterior scalene, we just see a very small portion of it. You can even see it. There it is right through there. So remember, the easiest way to sort of identify where that posterior scalene really is by locating the anterior middle and then seeing that the posterior is just immediately behind it. And of course, we said with the middle and anterior scalene, we could easily identify that. Why was that? What structure is passing between those two?
Brachial plexus.
The brachial plexus and also the, what, blood vessel? We had a brachial plexus that's sandwiched in between there, but then we also said what else is passing in there.
Is it carotid?
Carotid.
Axial artery.
So go a little closer.
Vertebral?
No, but the vertebral comes off of it. That's where that subclavian artery is going to pass through, and then it's going to kind of keep going past the border where that first rib ends, and then it'll become the axillary artery. You spend a lot of time looking at axillary artery and musculoskeletal, okay? And you saw subclavian last quarter as well in visceral anatomy. So again, let's turn up the detail and let's just see what we can see there. Okay, we can see a branch coming off through here. We can see a transverse cervical artery that's passing right over through there in that posterior triangle. And the transverse cervical artery is going to continue going all the way down, but it's also going to typically give us our dorsal scapular artery. So let's add that on real quick just so that we can see it. Dorsal scapular artery is going to travel with what nerve? Pretty easy, not a trick. You can even see it written right there.
Dorsal scapular nerve.
The dorsal scapular nerve, right? So let's tag this here, let's tag that there, okay? So we can see our dorsal scapular artery, oops, sorry. Right through there. And we can see that it's a branch, or it's a branch coming off of that transverse cervical artery. Now the way that you're gonna know what it is basically where it goes. Now I've got it highlighted, which is why we can see the entire length of it, but if I tap it again, it disappears, right? What does the dorsal scapular nerve innervate? What three muscles?
Rhomboids.
Rhomboid minor, rhomboid major, and
Levator.
the levator scap. So it's gonna go deep, and then it's gonna go kind of in front. So the reason why we can't see it from this point of view is because it's in front of it. So in order to see it on the cadaver, we typically would have to cut this, and then we could see it. Okay, it's like we can see just a little bit of it right there. Normally you gotta cut those rhomboids away to see it. So again, the dorsal scapular nerve would also follow that same position. And what nerve root did we say that comes from?
Is it 5?
C5. So directly from C5, we get the dorsal scapular nerve, goes to rhomboid minor, major, levator scap. And we said if there was paralysis or an issue with it, what would happen to the scapula?
Flaring.
They would flare. Okay, so flare scapula, pretty common board question. Okay, so any question about what that artery is? It's running transverse. This is one of the things that can be anomalous where you see the dorsal scapular artery coming from, okay? So here we can see it coming from a different place. It's not coming off of the transverse artery. Instead, we're seeing it actually, I believe it's actually got the root in this cadaver from the axillary artery, or excuse me, from the subclavian. So again, there's some inconsistencies between some of the texts that you see. Okay. Now, and that's the omohyoid. Omo means shoulder. It goes specifically to the scapula itself. We'll highlight it there. And yesterday we said if we were to have that tagged on a test, we want to be specific as in tagging either the superior omohyoid or superior belly omohyoid or the inferior belly of the omohyoid, okay? Now I would make it pretty clear. I'd either tag it like up here or I would tag it down here. So it's not gonna be like in the middle of these two things like that. I would even leave the sternocleidomastoid so that you can clearly see one's superior, one's inferior, and try to make it a little bit easier for you. Now in this area, we also saw a bunch of what? Superficial cutaneous nerves. Okay, so let's take a look at those. Now, if we use the sternocleidomastoid again as our landmark, we can see these nerves that are coming out from under it. See, there's one going this way, there's one going this way up here. We see one going across, and we can even see these guys coming down like this. Okay, let me just draw over the top of those so that we can see them a little bit easier. So one's coming up and going this way. Another one's gonna come from that same general area, and typically it's gonna do this, but it's also gonna give us some of these other branches. One of these are gonna do this number. And yeah, you'll see multiple branches coming off of it. And then typically you'll see another one kind of coming from this area and then going and piercing through the platysma. So what these are superficial cutaneous nerves of the neck. So when I draw it, I'm drawing just this one singular line, but obviously that's not reality, right? Those nerves have got to fan out and they've got to spread to cover all of this area because we want to be able to feel everything on every part of the neck, right? So when we look at the models, we may see these fan out to several different things, but they'll always have one root that's going to a specific area. So the very first one that's going back towards the occiput is the lesser occipital nerve. And if we look right through there, we can see it actually pop out from where the sternocleidomastoid is. Lesser occipital nerve may fuse together with the greater, may even join together with the Snetz nerve, which is the greater auricular nerve. Remember, auricle means ear, just like we saw our right and left auricles of the heart last quarter in visceral anatomy, meant to be kind of ear-like. This one here is our transverse cervical nerve going across. Pretty clearly transverse, right? Sometimes it won't be. Sometimes it'll be up a little bit, sometimes it'll be down a little bit, okay? But for the most part, it's always 1, 2, 3, the third nerve coming down. And then you come to the supraclavicular nerve, which we pointed out a minute ago because it was gonna pass through the platysma, right? So here's our anterior, our middle, and that posterior supraclavicular nerve. Okay, and again, those are all superficial nerves. Now those are coming from something called the cervical plexus, okay, and we'll take a closer look at that next week, and we'll see the roots of that, and there's some other nerves we want to see as well. I'm going to delete our drawing here. Internal jugular vein, anterior jugular vein. And do you remember what's draining into this external jugular vein just behind the parotid gland? We saw it yesterday. It's going behind the mandible. No, good guess, huh? So that's the retromandibular vein. So if we remove that here, and we look behind as it continues up through here behind the mandible, we can see the retromandibular vein, and we can see it's gonna drain into that external. Okay. We can see the internal jugular vein is gonna be traveling with the carotid artery, and there's a nerve right there in between it. Do you see that nerve in between there? Let's see if I can tag it for you. The vagus nerve. So remember we said that the vagus nerve was going to travel inside the carotid sheath along with the carotid artery and then also the internal jugular vein. So those three structures are running together, all wrapped up nice and tight. But we also said that the carotid artery was going to do what? Bifurcate, right? So common means it's going to split. So one is going to go posterior as the internal carotid artery, and it's going to go inside your skull and contribute to the circle of Willis. The other one's going to stay external, and that's the one that's going to give us all these other branches to our face, thyroid gland, and the larynx. Okay. Does anyone have any questions about this stuff here, kind of in that posterior triangle? Just so that we can see some orientation. Okay. So we can see this right through there. Okay. Let's get rid of the clavicle. And of course, we're all going to remember visceral, right? Remember, we had our heart down here. We had our arch of aorta coming up and doing this number, right? And then we had it coming up as the brachiocephalic here, right? And then it branched into that common carotid and then continued as the subclavian, right? But then on this left side, what happened? It immediately became the, yeah. So at this point, things are different, right? Everything else is the same beyond that, okay? Everything else is bilaterally symmetrical. It's just at the root where we see that there's a discrepancy between the two. I'm not really gonna test you on this. I just want you to make sure you keep connecting the dots between the different classes you've taken so that you can see how it all pieces together. It's easy to forget that. Okay, so let's just move this back down. And so the first thing we're gonna do is take a look at this common carotid. Give it a nice bright red color, because that's gonna be the root. We said if it's got the name common, what's it gonna do? It's gonna split. It's gonna bifurcate and become something else. Now, where it splits, we get the external carotid, which essentially is gonna give us a ton of branches to the face. And then it's also gonna branch into the internal carotid. Okay. Internal carotid, we're not that worried about right now. That's gonna go inside of the skull. It's gonna contribute to the circle of Willis, and we will look at that, but we're not really worried about that today. So let's go ahead and we'll remove that just for the moment, just so we don't get distracted. Now, as we continue following the external carotid, and I highlight that, we're gonna see, number one, that it kind of stops as it gets there, but it really doesn't stop, it just changes names, okay? So let's go ahead and we'll highlight it, a little bit of a different color, and we'll tag it. So now we have the external carotid, and again, it doesn't really stop, it just kind of transitions to a different name like we've seen in the past with other stuff. Now we can see there's a very first branch that comes off the external carotid, and that's gonna be our superior thyroid artery. If I can get it to tag. Right there. Okay, superior thyroid artery is gonna be that very first branch. Now, the next branch is gonna come off. We're gonna turn it just a little bit so we can actually see it, because from the other point of view, it didn't look like the next branch. But here we can see one, and now we see two, right? See that second one coming off? That is the lingual artery. As the name implies, it's gonna go to the tongue. And again, if I put it back this way, it doesn't look like the second branch, right? So on test day, the table will be unlocked in the sense that you can move it around. So you may come to the table and it may look like this, and you're like, okay, well, that's gotta be the third branch or something like that. After you say that to yourself, touch it, move it, and say, okay, 1, 2. Okay, that's the second, not the third branch. Does that make sense? So that's the lingual artery, which is the second branch. Now, the next branch that comes off is this guy right through here, and that's the facial artery. Now, I would say the facial is the easiest one to be able to identify because it's gonna come out from underneath the mandible, okay, and it's gonna go across the face. Now, it's gonna give us a bunch of branches that are superficial. It's gonna give us our inferior labial artery, superior labial artery. It's gonna continue up into the nose as well too, and then continue up even there by the medial canthus of the eye. Right. Now, don't forget here at this bifurcation for that artery, that's where we have the location of the carotid body and the carotid sinus. We said the carotid sinus was a neurological stretch receptor or a baroreceptor. So it's kind of getting the pressure of your pulse as it goes through, feeding that information in through the glossopharyngeal nerve, and it's giving feedback as to whether or not there's too much pressure, is there too little pressure, and then your autonomic nervous system's gonna take over and make changes. And then we said the carotid body, that was the chemoreceptor, right? So it's detecting the presence of something like CO2 and then making changes possibly to respiration to accommodate for those. So we don't really see that here, right? And I'm not gonna test you on that either. I might tag either here, or I would tag down here, but I'm not really gonna tag in the middle and ask you to tell me carotid body or something like that. I will say we probably could actually, I might be able to find it. If I can, I'll show it to you, but I won't tag it. Any questions about common carotid? Everybody good with the external and then these 3 branches we saw coming off of it? We said a minute ago that there was a nerve that travels with it. Let's see how much I can get rid of without losing the nerve. That kind of goes away right there. And let's see. Let's just highlight it. That's the vagus nerve. Yeah, so you see this big nerve here? You see how it's going all the way up inside the skull? So it's traveling within that carotid sheath. And the thing is, with the cadavers, that carotid sheath has either been removed or the cadaver has kind of been sitting a different way, and so it doesn't look like it's inside there. But anytime you look at the models, you always will see that vagus nerve right on top of the carotid artery. And then it'll travel with the internal carotid because it's going up to what hole in the skull, or rather it's coming from what hole? You remember what opening that is? Cranial nerves 9, 10, 11, they all come out the same place. Jugular foramen, nice, good job. Jar your memories. Okay, so again, all this other stuff that I have here, like on test day, I wouldn't have that. I would just have a nerve that would be traveling with the carotid, okay? So it won't look quite like this, but you can see it. And again, if I just tag it right through there, you can see where it's running. Now, of course, the vagus nerve would continue going down, which would be one of the differences between all these other nerves. The phrenic nerve, which we're going to see in a minute too, would also be traveling down, but really only the phrenic nerve and that nerve are going to be the ones that continue going all the way down through the chest, okay? Does that make sense? All right, let's get rid of all these nerves because it's just a little bit too much. Let's get rid of those veins again. Okay. Now let's look on this other side here. Okay. So this is where it can get a little bit confusing. And I'm going to get rid of that carotid artery on this side just to make it easier for us to see the branches of that subclavian. Okay. So the very first thing we can see here is going to be the costocervical trunk. It's one of those things, again, where if you look in a Netter's atlas or you Google for an image or something like that, you may actually see the costocervical trunk coming off down here. But on all the cadavers I've seen so far, it's coming off that first branch. So costocervical trunk is going to give us our deep cervical artery, which we won't see on any of the models. We also won't see the costocervical trunk on any of the models. And then it gives us our supreme intercostal artery. We won't see that either. Okay. If I tag here, we're going to notice that the thyrocervical trunk almost seems to be like 3 separate things. But remember, it's just like the celiac and just like the thoracoacromial trunk, we have this little nub. And then we have these other branches that kind of come out of it. Same thing here. So even though these look like 3 separate structures, they're all feeding into this one trunk. Everything beyond the trunk where it starts to branch really becomes something else, okay? So in this situation, let's add the supraclavicular artery on, if we can. If we can, I'll draw it. So the continuation and really this entire thing after you get past the trunk is going to be the supraclavicular artery. Let's see if we can add on the transverse cervical. Let's put that on. Okay, here we can see the second branch that's coming here is the transverse cervical artery. And then the third branch, it's going to go straight up, is going to be the inferior thyroid artery. Okay. So if we were looking at it like in an atlas, typically what you'll see is you'll see this nice root right through there, and that would be the thyrocervical trunk. And then we would see one of these arteries going this way towards the shoulder, and that would be supraclavicular. We would then see like another one that kind of come up a little bit more, but then it's going to go around like this, and that would be that transverse cervical artery. And then you'll typically see the next one just kind of coming up like this and going over to the thyroid, and that's the inferior thyroid artery. So thyrocervical trunk has 3 different branches, okay? Supraclavicular, here's the transverse cervical artery coming this way, and then as it continues to go up, you have the inferior thyroid artery. Now I can appreciate that it's a little confusing, right? That's a little confusing, right? I get that. Okay. But that's just the way the body is. It doesn't always listen to us. So let's look at what normally is the very first branch that's moving superior, which is going to be this guy right through here. And that's our vertebral artery. We said the vertebral artery was going to enter the cervical spine where?
C6.
Typically the transverse frame in a C6. Could it enter somewhere else like C7 or C5?
Yes.
Yeah, it could do that. If I wanted to assess an artery, what would be a good modality, or what could I use, like an advanced imaging type thing to assess an artery, which you may or may not really know yet? So if I'm concerned about a patient's artery, maybe there's concern about calcification or some sort of stenosis, typically we'll refer them for something called a Doppler ultrasound. So Doppler ultrasounds are typically the standard for taking a look at that. If you thought the patient maybe had suffered a stroke but also had some of that, you may send them in for the Doppler ultrasound, but then also send them in for an MRI of the brain to see whether or not there was any kind of death of any tissue, which would leave like some little patches. So again, arteries, typically we're thinking Doppler ultrasound, we're thinking part 2, 3, and possibly 4 boards. Okay, when we're thinking about that, but just kind of keep that on the horizon, that that's how you would assess an artery. And hopefully you'll probably talk about that again in visceral diagnosis at some point in this term. Any questions about the branches of the thyrocervical trunk?
Just a quick question.
Uh-huh.
So here, looking at the presentation, showing that after the thyrocervical trunk, we have suprascapular.
Yep, sometimes that's the way it goes.
So it could be either or.
Yeah. So here, and if you look at netters, you see suprascapular coming directly off the thyrocervical trunk. But in some images, you'll see it coming directly off the subclavian arteries. Yeah, and I appreciate it's confusing. Yeah, unfortunately, it's not always straightforward. Yeah. Any questions about these branches? It's going to be that internal thoracic artery. So if you remember last quarter, we took a look at this artery that came off the subclavian. It went this way, and then one part continued to the stomach, and then one did this, right? So we had the internal thoracic artery here in between each one of our intercostal spaces, and we could see that. It continued as the superior epigastric as it passed the xiphoid process and diaphragm, and then it also went along the angles of the ribs here, or the costal margin here rather, as the musculophrenic. So again, that branch also is coming off the subclavian, just to keep it in mind. I'm not really gonna ask you that on any of your tests, but just keep connecting the dots. Thank you. So we've got the branches of our carotid artery. We're gonna see more of that. We've got the branches that are coming off the subclavian artery as well too. And yeah, they can be anomalous. And again, you know, when I was here, we had, let's see, we had maybe, so again, remember that the anterior triangle is divided by that sternocleidomastoid. As we move to the front here, okay, everything here is the anterior triangle, but then remember, we also discussed that there's lots of other triangles, right? There's a submental triangle, there's a carotid triangle, there's a muscular triangle, there's a bunch of triangles. None of those triangles are testable on your lab day, okay? We'll talk about them in lecture, and we'll talk about being able to identify certain structures in each one of those that are important for your test. But at the same time, on lab day, you don't have to worry about it. So you got that on your list. You could mark it off if you wanted to, or just put a line that says don't study or something. It's only there to give you reference. I'm gonna remove the sternocleidomastoid just so that we can see things a little bit easier. And then we're gonna blow this up just a little more. Also gonna get rid of these veins. So we're just looking at the muscles, okay? So again, the very first thing we can see here is this omohyoid muscle. Omohyoid has the name hyoid in it, right? Essentially, all these muscles we're about to look at are named according to what they connect. So whatever two structures they connect, for the most part, that's what they're called. There's a couple exceptions to that, but for the most part, that's what it is. So how do we divide those then? We divide them via the infrahyoid and suprahyoid muscles. And it looks like I'm gonna have to get rid of the mandible for her to be able to see those. Get rid of too much. Forget this one. She had a kind of a short, stocky neck, so you can't really see it. Let's see if we can just highlight the hyoid. I just want you to see where it's at. Just highlight it. Make this nice, bright. No, let's just highlight it again. So we can see the hyoid here. I don't really like this because you can't really see it in relationship to the mandible. Let's go back down here on this one. I'm just gonna add all the muscles back in through there. See it right there? So it's pretty easy to tell the difference between which one is which one. But if I was gonna tag it, I'd tag the anterior digastric here versus the posterior there. And I'll show you that from the side in just a second. But let's go ahead and give it a little bit of color. Lighten it up just a little bit. Now up under there, we see this big flat muscle. It's the mylohyoid. So the mylohyoid kind of makes up the floor, what we would feel here. So if you palpate here, you are palpating the anterior belly of the digastric, but the flat portion or the floor that it sits on, if you will, is the mylohyoid. So it's all this up under here. And when we get to visceral diagnosis for the head and neck exam, you guys will be doing the submental lymph nodes just right in that area.
Question, is it mylo or myohyoid?
Mylo, yeah,
Okay.
yeah.
Cool.
Yeah, and if you see a discrepancy between spelling here versus your sheet, go with the one that's on here. Now, I'm gonna get rid of half of this body so that we can see the next muscle that's just one more layer up. I'm gonna do that by hitting our silver or our grayscale here, cutting the body in half, turning it just a little bit. Okay. Now, when I do that, we can still kind of make out this muscle here as the mylohyoid, and then we go to the next muscle up, and we come to the geniohyoid muscle. So the geniohyoid muscle is just above the mylohyoid. Okay. Now it's only highlighting a small portion of it. Okay, so it's a little bit more significant than what you see there. Now, honestly, the mylohyoid, probably like surface space that it covers, is maybe bigger, even though it's kind of smaller. When we look at that on the model, we'll see it from a different point of view too. And that'll probably be what we do for the first like maybe 5 minutes of our next class. I'll just review this stuff on the models. Now I'm gonna go ahead and put the body back on, or I'm gonna put it back together. We'll undo that. Now we're looking at the side, so here's the mandible, and I'm gonna get rid of that. Make it just a little smaller. Okay. We're gonna get rid of the masseter. Masseter muscle is one of those muscles of mastication, not masturbation. Mastication. Mastication means to do what?
Chew.
To chew. Chew, chew, chew food. So here we have that posterior belly of the digastric, anterior belly of the digastric. And if you look right above it, we can see another muscle. Okay, that next muscle is coming from your styloid process, and it's going to your hyoid bone. So what are we going to call it? Stylohyoid. That's it. There'll be another muscle that we'll see a little while that goes from your styloid process to your tongue. Another word for tongue is glossus. We'll call it styloglossus. There'll be another one that goes to the palate, to the glossus, paladoglossus. So a lot of these muscles are just named according to where they are and what they connect. Any questions about those suprahyoid muscles? So we've seen the nerves that we need to see for the superficial neck. We've seen the muscles that we need to see for all the superficial neck. We've seen the blood supply for all the superficial neck as well too. So that's pretty much everything that should be on our week 1 list. So what we need to do now is just have you go play with it. Okay, go take